Thank you. Well, the title of the session implies different, but within this presentation no cost effectiveness analysis was done, but we compare two types of screening. Based on a previous study used computer simulation, it was speculated that the number of people using insulin might be less when people were detected by population-based screening instead of care as usual. And therefore in this study we compared two types of screening, or actually population-based screening with usual care, which applied opportunistic screening in the Netherlands, and we looked for insulin prescription and glycemic control 7 or 10 years later. The 7 years is because it was speculated that the lead time of population-based screening was about 3 years. For this we included 3 cohorts. One cohort is the addition NL cohort, which is actually a cluster randomized controlled trial in which people were detected with type 2 diabetes with population-based screening. So half of the participants during the first 5 years received intensive treatment, and the last 5 years it was according to national guidelines, and the others receive the national guidelines. We looked at insulin prescription and glycemic control, used logistic and linear regression modeling, adjusted for indicates over here, and also include adjusted for cohort, which is not mentioned here. And we performed a sensitivity analysis in which the people from the intensive treated arm were excluded. What we can see here in the table are the characteristics of the groups. We see in the addition group the people are on average a bit older, a bit more men, but in all groups people were well controlled. This is all data from the index year 2014, so after a duration of 10 or 7 years diabetes. And with regard to the insulin prescription, we saw people diagnosed during care as usual had a 1.5 or 1.8 factor higher chance of getting insulin prescribed 7 or 10 years later. We also saw lower glycemic control in the screen detect group. The mean difference you see here are actually the percentage units, and in millimole per mole it is about 1.5. So what we conclude was if you apply population-based screening, the number of people using insulin might be lower, but with regard to insulin control it is also lower, but actually both types of screening show well-controlled glycemic control on the long term.